You just moved through a dense amount of cardiovascular content. This section is different. We're distilling it. Cardiology simplified. These are the mental anchors you need to recognize patterns quickly and confidently. Let's start with the foundation, heart failure. When the EF drops below 40%, this heart does not survive on one medication. It needs 4 pillars holding it up: ACE or ARNI, evidence-based beta blocker, mineralocorticoid antagonist, SGLT2 inhibitor. If one pillar is missing, the structure is unstable. Build on all 4. When you see a mechanical valve, there is no gray zone. Left side, no. Right side, yes. On the slide, that is. DOACs are not approved. Warfarin, also known as Coumadin, only. And remember your INR targets. For an aortic valve, you want 2 to 3, and for a mitral valve, you want 2.5 to 3.5. Know the hard lines. This is one of them. When you see an INR of 3.8, I want you to slow down. The key question is the patient bleeding? If the answer is no, this is not a reversal situation. We hold the dose, we reassess, we adjust. Advanced practice is often about restraint, not reaction. Okay, this one is a big deal. If a patient has a drug-eluting stent and they're on clopidogrel, also known as Plavix, that medication is not optional. Stopping it early dramatically increases the risk of stent thrombosis, and stent thrombosis is often fatal. So when a patient says, "I feel fine, can I stop this?" the answer is no, not yet. Dual antiplatelet therapy after a drug-eluting stent protects that newly placed device while the vessel heals. This is where patient education saves lives. Adherence here isn't about convenience. It's about preventing catastrophe. Amiodarone works, but it comes with baggage. This medication affects the lungs, the thyroid, the liver, and more. So when you prescribe it, you are committing to monitoring baseline labs, ongoing surveillance. If a patient on amiodarone comes in with cough, fatigue, vision changes, that's not random. That's a clue. You don't just control rhythm, you manage risk. NSTEMI. Beta blockers should be started within 24 hours. But, and this matters, only if the patient is hemodynamically stable. So before you automatically prescribe, you check. Are they hypotensive, bradycardic, in cardiogenic shock? If they're stable, beta blockers reduce myocardial oxygen demand and improve outcomes. If they're unstable, you pause. Guidelines give you direction. Clinical judgment tells you when to apply it. If the LDL remains elevated on high-intensity statin therapy, we do not abandon the statin. We add. Ezetimibe is the first add-on. Then we recheck and reassess. Think ladder, not leap. When chronic kidney disease and diabetes are in the picture, this is no longer just about lowering blood pressure. It's about lowering intraglomerular pressure. ACE inhibitors and ARBs protect the nephron. They reduce stress on the filtration system and slow progression. So when you see CKD plus diabetes, I want you thinking organ protection, not just numbers. As you step back and look at these anchors, notice the pattern. Clinical prescribing is not random, it's structured. We build pillars in heart failure. We recognize hard lines in anticoagulation. We show restraint when labs are slightly off. We protect organs, not just numbers. We escalate therapy stepwise. Guidelines give us the framework. Clinical judgment is how we apply it. That combination, structure plus reasoning, is what defines advanced practice. You are not memorizing answers. You are building patterns.